Welcome to week 3. We're going to go through 2 PowerPoints for this week. So we will just get started right away. As soon as my screen shares. There we go. So we're actually going to start with a PowerPoint that's called Cytochemistry first. And I don't know if this is a new chapter number in the new edition or if they took it out and combined it into another chapter. I feel like it might be combined into another chapter now. It used to be its own separate chapter in the old edition. But at any rate, no matter what, wherever it's found in that new book, it is essential that we know cytochemistry. So this is going to basically go through a ton of different stains that are used to help with identifying leukemias. So that's kind of what cytochemistry involves, and we see that right here. The principle is it's going to study chemical elements that are in cells. So it could be a stain that targets an enzyme or a lipid or glycogen. It will target something in those cells to help identify what kind of cell it is. By knowing what kind of cell it is, it helps determine what kind of leukemia is occurring. So it's just like it says here, stain cells to help differentiate diseases such as acute and chronic leukemias. Now, of course, most of the time it's a lot of flow cytometry that we use instead. And flow cytometry is an analyzer. It's a special hematology analyzer, so not just everybody gets to work on it. You get trained specifically into flow cytometry if you have a lab with it. And it will basically look for certain cell surface markers, and then those surface markers used together will determine what cells they are. But cytochemistry is still something that we should be aware of, know how to interpret in different case studies, things like that. So that's what we'll cover here. So as far as specimen types that we can get in to use for staining, anything would really work here. That's listed: bone marrow, lymph nodes, sampled, peripheral blood. Fresh smears are usually best, but we could use smears that have been kept at room temp for a few months for certain methods. If it's anything looking for an enzyme, that really wouldn't work. All right, so here's where we're going to get into the gist of the chapter. So first stain up is myeloperoxidase. You might see it as the initials MPX. So myeloperoxidase is a stain, and it's specifically staining that enzyme, that myeloperoxidase enzyme, and that is an enzyme found in the primary granules of neutrophils, somewhat eosinophils and stuff too, but mostly with neutrophils. And the purpose of the stain is to differentiate whether you have AML, which is acute myeloid leukemia, or ALL, acute lymphocytic leukemia. So it's going to stain positive for AML, negative for ALL. So basically how the stain works is when you have hydrogen peroxide present, that myeloperoxidase will oxidize the dye substrates and create a stain color, a colored reaction, a red-brown stain color reaction in this case. This part you don't need to memorize. I'm not as worried about this. What you do need to know is, what does it mean? So again, to differentiate AML from ALL, AML will be positive. So the way that it works with acute leukemias, in acute leukemias, a lot of your cells are blasts, those really immature young cells that really look alike. Again, we cannot tell a myeloblast from a lymphoblast, from a monoblast, from a pronormoblast, just with your eyes under the microscope. They all look very much, they're large, they have dark blue cytoplasm, they have nucleoli in them, they just look alike. So when people have different leukemias, it's going to be affecting one cell line for that leukemia. And so we have to determine what blast cell is this, because by knowing which type of blast it is, it tells us which type of leukemia it is. So in the case of myeloperoxidase, if it stains positive, that is telling us those are myeloblasts. They belong with the neutrophil and granulocyte lines, like the neutrophil and eosinophil and basophil lines. We know it's not lymphoblasts. We can say ALL negative then. So that stain and that stain reaction color, that's how we can interpret and figure out what type of leukemia line is affected. Now, the key is the very last blue bullet there that says you have to look at the blast cells for the reaction. Because if you have myeloperoxidase enzyme in all the primary granules of neutrophils, every single one of them segment of neutrophils in our blood. That's 20 molar, number one cell usually if we're healthy people. And so if we all have neutrophils with all these primary granules, we all have positive neutrophils. We all have the myeloperoxidase enzyme in there. So all of our neutrophils will normally be positive. But in acute leukemias, we're not caring about the neutrophils. Those are nice cells. We're looking at the blast cells. So you have to look for the blast cell reaction to know if it was positive or negative, because neutrophils will always be positive. That's not going to give you any extra information. So again, knowing about the stain is it's staining the myeloperoxidase enzyme in the primary granules of neutrophils, and it's saying AML positive, ALL negative. And again, you are looking for the reaction in the blast cell. So there's kind of a picture of what it would look like. There's 3 cells. I know there's an arrow. It's pointing, that arrow. Ignore the page number, by the way. That page number is not correct anymore. But there's 3 cells there that are all staining positive blast cells for the myeloperoxidase enzyme. The arrow is pointing to something that we call an hour rod. An hour rod is basically these primary granules that have condensed together into a rod shape. So you see where the arrow is, that's a rod shape. That is an hour rod. So it's made of just primary granules. So of course, if it's made of primary granules, it will stain really intensely with that myeloperoxidase stain, because all those primary granules have that enzyme in them. So it will really pick up that stain very well. Now, hour rods are very key findings, and they always indicate AML. So we should never ever see an hour rod normally. It's always an abnormal finding seen with leukemia, and it's specifically seen with AML leukemia. So you should always associate it with that leukemia, and you'll see it in the cytoplasm of those cells. So there is another stain reaction, positive myeloperoxidase stain. So there's a bunch of cells there that are positive. You're not going to have to interpret these stain reaction colors. I mean, we're not professionals. We're just learning what they're used for. Okay, so our second stain is Sudan Black B, or SBB for short. Same purpose. Again, it's used to help determine if you have AML or ALL. So it'll be positive in AML, negative in ALL. In this case, it is staining the lipids inside the primary and secondary granules of neutrophils. So it is targeting the lipid inside those primary and secondary granules of neutrophils. Again, you're going to want to look at the blast reactions. So look at the blast cells, because neutrophils will normally be positive for this. So we want to just look at the blast cells to interpret. And so you should see that myeloblast would be positive, so that would tell us we have an AML, whereas lymphoblast will be negative. So we know it's not an ALL. Here's what it would look like. Again, ignore the page number. That's not right, but you kind of get the gist. It looks similar to the myeloperoxidase one. All right, next one up is esterases. There are actually 3 different types of esterases, and this kind of gets a little bit more confusing now. So first, we have the non-specific esterases. I have non-specific underlined, and those consist of 2, alpha-naphthyl acetate and alpha-naphthyl butyrate. You do need to remember that the 2 non-specifics are those 2. So remember that those are both non-specific esterases. And then there's a third one called a specific esterase, and that one is called naphthol ASD chloroacetate esterase. You also need to remember that is the name of the specific esterase. Now, the specific esterase will only stain myelocytic cells, so just the granulocyte lines like neutrophil, eosinophil, basophil line. So it will tell us if we have a leukemia that's in that myelocytic line there, the granulocyte lines. The non-specific will stain monocyte cells, monocytic cells. So that would tell us if we have some sort of monoblast happening, which would be involving the monocyte line. All right, so the principle, again, this is just information. You don't have to memorize the principle. It's just saying the esterases are an enzyme that will hydrolyze ester. There will be a compound released, and that will combine with the salt, producing a colored product to show the stain reaction. So that's it. That's how it comes up with a colored stain reaction. You don't have to remember it. So here is the specific naphthol ASD chloroacetate reaction here in the picture. Again, that is specifically showing a positive reaction in myelocytic cells. So you could say like the neutrophil, the eosinophil, the basophil cells, so myelocytic cells. It would be a negative reaction in monocytes. Whereas the non-specific esterases like alpha-naphthyl acetate and alpha-naphthyl butyrate will show a positive reaction in monocytes. Neutrophils will be negative. So it can tell us whether the leukemia is involving the neutrophil line or the leukemia is involving the monocyte line, basically. So there's the butyrate one, again, showing a positive reaction in monocytes. So esterases get a little confusing, but just remember the names of the two non-specific and that they're both used to stain positive for monocytes. And then remember the name of the specific esterase, and then that's used to stain myelocytic cells. Our next stain is periodic acid shift, PAS. This one's a bit different. This one will stain positive for ALL, and it stains positive for one type of AML. It's the erythroid type of AML, so the red cell line. So there is a leukemia called erythroleukemia. It will stain that positive, and then it will stain ALL positive. All other AMLs are negative. So this one will target glycogen. So there will be glycogen inside certain cells, and those cells that have that, it will target. So you do need to remember that periodic acid shift will target that glycogen. And so the rest just talks about how it forms a colored product to show that positive reaction. All right, so here's your interpretation. This gets confusing, but what I really want you to remember is the bottom one. Again, in that erythroleukemia, erythroblasts are positive for PAS. And then the other thing that's positive, oh, it doesn't even say it on here actually, is ALL. It says it in the heading up here at the top, ALL. So ALL is positive and the erythroleukemia is positive. And so in this picture, it's showing those glycogen stains that have reacted, showing positive. And then there it is in the erythroleukemia, so in the erythroblast. All right, there are antibodies that you can use as an actual staining process, like this one is factor VIII. This is specifically looking for megakaryoblast leukemia, so kind of involving that platelet line. I don't really test you on this. Megakaryocytic leukemia is extremely, extremely rare. So we're not going to really talk about this again, but it's just mentioned here. And then, of course, LAP. We learned a little bit about LAP last week, leukocyte alkaline phosphatase. We learned last week that it's used to help tell apart CML from a leukemoid reaction. So CML, of course, is a type of chronic leukemia. A leukemoid reaction, if you remember, is a very over response to a bacterial infection. So your white count goes way high, and you start seeing some immature granulocytes. So in other words, a leukemoid reaction and CML on the blood can look similar, but they're, of course, two very different treatment processes. So LAP can actually tell them apart. And so that's what we kind of learned last week. So LAP is an enzyme. When you look at the name, leukocyte alkaline phosphatase, so it is an enzyme found in the secondary granules of neutrophils. So when there's going to be a whole colored reaction again to make the stain reaction, this is going to get to be a little bit more in depth though on how we use this stain, and you do need to know this process. So basically, once they do the stain and then they look under the microscope for the reaction, they will grade the cells based on how much of that stain they took up. Is it just slightly? Is it heavily stained? Like, what is the amount of activity? And now here's the catch. All the other stains that we've been talking about have been mostly looking at the blast cells for a reaction. The LAP stain is looking at the mature neutrophil cells and bands. So we do want to look at the segmented neutrophils and the band neutrophils in this stain. All the others are blast cells. So they will basically look for 100 segmented neutrophils and band neutrophils and then grade them on how significant they took that stain up. Whether there's 0, no stain reaction at all, up to 4, which is a very heavily stained reaction. And I think I'm going to come back to these slides, but here's a picture of that. So letter A would be, that's a normal looking neutrophil, right? There's no stain reaction. It's just totally normal looking. Letter B is a 1. You can see it's slightly getting more heavily granulated, not a ton, but a little bit, so that's a 1. Letter C there on the right is a reaction of a 2. D on the bottom is a reaction of 3, and then of course E on the very bottom right is a reaction of 4, very heavily stained. So once they apply the stain, they're going to go through the slide, look for 100 of these different segmented neutrophils and bands, and grade them, whether they're 0, 1, 2, 3, or 4, based on the reaction of the stain. Once they do that, now I'm going to go back to the slide I skipped. So they have the score in the 1 column, 0 through 4, and then they write down how many cells they found with each score. So in this case, they found 20 cells were a score of 0, 45 segmented neutrophils and bands were a score of 1, 25 were a score of 2, 5 were a score of 3, and 5 were a score of 4. So of course, that makes 100 cells, 100 neutrophils that they counted. Now, the next step that you have to do is multiply across. So 0 times 20 is 0. Anything times 0 is 0. 1 times 45 is 40. 1 times 45 is 45. My gosh. 2 times 25 is 50. 3 times 5 is 15. And 4 times 5 is 20. Once you've multiplied across, then you add up that last column. So 0 plus 45 plus 50 plus 15 plus 20, and then that's your lap score. So in this case, the lap score was 130. So ignore the page number. That page 402 is not right anymore. But this is the example. You will need to be able to calculate this on tests. So be very familiar with how to calculate this on exams. Now, a normal reference range should be 20 to 100. Anything between 20 to 100 is normal. Here are some different scores, different diseases that result in other scores. You do need to know this chart. So those that will show an increased lab score, leukemioid reaction. Actually, leukemioid reaction can sometimes be normal, but it can also be high. If you're late in pregnancy, that would cause an increased lab score, and then polycythemia vera, which is a disease we'll learn soon, that will cause an increased lab score. Decreased lab score, so less than 20. CML, definitely. That usually sits down around 12. Paroxysmal nocturnal hemoglobinuria, sideroblastic anemia, and myelodysplastic disorders all will be a decreased or low lab score. So do know those examples of which ones will cause a high and which ones will cause a low lab score. All right. So that is the lab stain. That's probably the more complicated one, just by knowing how to stain and score it, and then which diseases go with those score. All right, moving on to our next stain, tartrate-resistant acid phosphatase. I know that tartrate resistant is like after the acid phosphatase, but usually they just say it in the beginning. So TRAP, TRAP. So basically, this is looking to diagnose one specific leukemia called hairy cell leukemia. So in the picture below, you are going to see what we call a hairy cell. And it's called that because the cytoplasm looks like hairiness, like it's all projected weird. This is actually a leukemia, and we'll learn this soon, that involves lymphocytes. So this is a lymphocyte, and their cytoplasm get these weird projections that we call hairy cell in them. So with hairy cell leukemia, those cells produce an isoenzyme number 5 in really big amounts. So all cells will produce certain isoenzymes of acid phosphatase, so they're acid phosphatase isoenzymes, but the hairy cell leukemias really produce a ton of isoenzyme 5 acid phosphatase. As a result, when they go through this whole staining process, that isoenzyme 5 is actually resistant to an acid that they're trying to add, this tartaric acid. Because it's resistant, that's how it gets the name, tartrate-resistant acid phosphatase. So we know that if it stains with this, it will be a positive confirmation of hairy cell leukemia. And so we just have to say, hairy cell leukemia, basically you trap your hairy monster is the saying to remember it. So trap is the saying, diagnosing hairy cell leukemia, so you trap your hairy monster. And then that's what it looks like when it stains. Again, ignore that page number there. All right, that is a lot of info. I know for some people that gets confusing. You guys will have a study guide on that this week to put the information in. You have to just know each stain in there, what it targets, what's the purpose, like what leukemia does it help diagnose, that kind of thing. Anything extra I might have mentioned, but the biggest things you take away on each stain is the purpose of it. So like what leukemia does it diagnose? What is it targeting in those cells? Is it targeting glycogen or lipids or, that kind of thing? All right, so the next chapter is cytogenetics. Thankfully, this is a much simpler chapter than the one that we just went through. So most of your information is in the other chapter for the week. Cytogenetics is basically the study of chromosomes. So there are a lot of different cytogenetic or chromosome abnormalities that can occur to create a leukemia. And this is kind of involving that looking for those chromosome abnormalities to help diagnose the leukemia, give a prognosis. Like some chromosome abnormalities are worse than others. So if a doctor knows that, they're going to have a better idea what the prognosis for the patient will be. It will also help them select which therapy would be correct, and then monitoring how that therapy is going. So all of that is done with, all that is found out with cytogenetics and knowing different chromosome abnormalities that are occurring. To look at cytogenetics, bone marrow is the specimen that we would want. All right, so we're not going to go too far in depth with cytogenetics. It's a big, big topic. And it's something I kind of leave for, like, if you ever want to go on for your 4-year degree or even specialize in hematology, you will learn so much more about this then. So for our purposes, we are going to get the gist of it, and I think that will get us through what we need. So again, leukemias are classified according to what type of cells that they affect and the clinical course, whether it's acute or chronic. So you'll notice that all leukemias kind of fall into one of 4 big categories. The 4 categories are acute lymphocytic leukemia, or you can call it lymphoblastic, doesn't matter, same thing, ALL. Acute myeloid leukemia, and that can also be termed acute myelogenous, acute granulocytic. It's the same thing. They love to change that middle word just slightly, but it all means the same thing. So that's AML. And then you have chronic lymphocytic leukemia, CLL, and then chronic myeloid leukemia, CML. So those are the 4 big categories of leukemia, and typically it will fit into one of those 4 categories because some of them have subcategories. So that's kind of how the overview of classification. Now, with that being said, the difference again between acute and chronic. Acute is much more rapid. It's probably a harder leukemia on the patient. The prognosis is, it depends on what type of acute leukemia they have. Sometimes the prognosis is really bad. Sometimes it's treatable. But basically, for our purposes in hematology lab, what we see is in acute leukemia, lots of blast cells. You will always see a ton of blast cells, typically like greater than 20%, and that would be an acute leukemia, is all those blast cells. And again, blast cells are really young cells that have no job, no function, and that's why it's such a tough leukemia and a progressive leukemia on patients, because they're filling up with these cells that don't perform any work, and it's doing its job on the patient. You know, it's kind of taking its toll. Whereas chronic is like it sounds. It's going to be, you know, people can usually exist with this for a longer period of time, and that's because they don't have that many blast cells. Yes, they have some immature cells, but a lot of their cells do have some sort of function and job still to perform their work. So they have less than 20% blast. So that's the main difference. Acute, lots of blasts. Chronic, hardly any blasts. They have more other types of immature cells. So the WHO is a World Health Organization that has classified especially the AML group there into subgroups. There's a ton of subgroups of AML, and there's one specifically that they have subgroups of because they are known chromosomal abnormalities. So there are a few AMLs that have very much known chromosome translocations that have occurred to create that leukemia. And so here's one example of a chromosome abnormality I absolutely need to know. We've mentioned this before. I think it was last week we mentioned this. In CML, chronic myeloid leukemia, there is that Philadelphia chromosome. And 95% of people who have CML because they got the Philadelphia chromosome translocation. So basically it involves a translocation between chromosomes 9 and 22. So remember, this is that whole oncogene. They had their oncogene ABL fused with BCR, so it's called the BCR-ABL fusion. As a result, it created this translocation of 9 and 22, and then that's what triggered the CML leukemia to start. So oncogenes control if leukemias will start. You know, they are the bad genes. We don't want them to be turned on and activated. And in this case, it became activated with this fusion and translocation to create CML. So that is a very essential abnormality to know, especially since 95% of people who have this leukemia have that chromosome abnormality. So it's very diagnostic for it. Now, there are a couple, I think it's an ALL that may also have Philadelphia chromosome involved, but for our purposes in this class, anytime you see Philadelphia chromosome, you always link it with CML, always. So that's what we're going to know it with. The other, so here's where I mentioned, there is acute leukemias like ALL that you may find the Philadelphia chromosome with, but again, for us, put the Philadelphia chromosome with CML instead. I want to just link to a CML for it now. All right, some other translocations. There's this AML with maturation. That's the name of the leukemia that has a translocation of chromosomes 8 and 21. I'm not going to really test you on that. It's just a mention, so but don't worry about it. There is one that we will definitely test on in the future, and that's acute promyelocytic leukemia is the name of the leukemia. And that has a known translocation of chromosomes 15 and 17. I do ask that you remember that it's 15 and 17 translocation to create the acute promyelocytic leukemia. And that is it for that chapter. So like I said, that was a little bit of a briefer one. You just need to know those couple translocations and just some basic information there. So we are good for this week. As always, if you guys have questions, please feel free to reach out. Otherwise, have a fabulous week.